Nice to see someone caught in the act, just drinking a little bit. Good evening, everyone, and welcome to our Facebook Live discussion brought to you by Veterinary Teleneurology. It's fantastic to see so many of you joining us from all over the world. We have people from Brazil, Canada, I've seen Egypt. We got people as well from Russia and other parts of the world. So thanks a lot for joining us. We have a great speaker and a great topic tonight. If it's the first time you join us, we've prepared some question to ask to our speaker, who is Louise Clark. And at the end of this Q&A, you can put your question to Louise, and I'd be delighted to put this question forward for you, for Louise to answer. That leaves me to introduce our speaker tonight, Louise Clark. Louise is a very old friend of Simon and I. We've been working together probably, I think, 18 years ago, it must be now. And only 18 months ago, Louise and I, we parted, road. But yeah, for a very long time, we've been working together. And I can tell you, she's a fantastic anesthetist, definitely a safe pair of hands when you have to do a complex surgery. Louise is currently head of anesthesia at Davies Veterinary Specialists in the UK. She is a diplomate of the European College of Veterinary Anesthesia and Analgesia. And she's also president of the section Pain Medicine of the Royal Society of Medicine. Tonight, Louise is going to talk to us about problem solving in neuroanesthesia. Simon will ask her a number of questions, and in the meantime, feel free to put in the comment box any question you may have for Louise. But leave me to leave the mic to Simon to start with this Q&A. Simon, I hope you're doing well.
Yep, thank you. Thank you very much. Oh, I think can you hear me? Because I lost your last few words. If it was a joke, I missed.
Sorry, the old time. I was getting.
Can't hear you. Oh God, hang on.
I think we can hear you. You can start, Simon. All fine.
All right. Can I hear you?
Yeah.
I can hear you, Simon.
Can you hear me?
Yeah, I can hear you.
I can't hear you. But I'm going to ask the first question, and then I'm going to sort that out. So, Louise, welcome. Thank you very much for coming. It is a great honor to have you, and a pleasure to see you again after all this time. One of our youngest friends, I'd have to say.
Absolutely.
It's going to be an interesting little session because Laurent wants to know if there's been any progress since chloroform for just knocking out his patients. So let's get started. And our first question is, which cases really are the ones that we should be worried about, and why? Laurent used to think that if they got off the table alive, that was a success. Is there something more we should be worried about?
Well, thanks for the introduction, Simon. Yeah, it's been difficult working without you, having to work with Laurent for 17 years. You can imagine there's been some problem solving going on. But yeah, it shows a bit of a graduation back in the 20th century, that sort of attitude. But I guess if we look at it from a bigger perspective, there's quite a lot of information from human practice that actually shows that the type of anesthesia that you undergo can really affect your long-term outcome. This is really important in cancer surgery, and that includes neurocancer surgery. There's a lot of evidence that inhalational anesthesia and opioids give poorer long-term outcomes with more tumor recurrence, and things like propofol tiva or locals give a protective effect. So that's major stuff. That's really making people making decisions about how anesthesia is actually going to affect long-term mortality, not just tomorrow. In addition to that, there's quite a lot of evidence of things like excess anesthetic depth, low mean arterial pressures, and we're not talking real hypotension, we're talking less than 75 millimeters of mercury, and the requirement for not much drugs that shows a really bad 30-day mortality in people. So, you know, these are things that we don't have much data on in dogs as yet. But, you know, taking it back to the practicals, if you bring in a case for a diagnostic procedure, as much as all neurologists love MRI, it's diagnostic, it's not therapeutic. What you don't want is a bad anaesthetic, making what was a stable patient considerably worse. You know, that doesn't do anything for anybody. So hence, I guess we worry about all patients, but some more than others.
And why have you highlighted or focused on comorbidity on this slide?
Well, Laurent's only given me 20 minutes to talk, and he knows that I can waffle forever. So I thought comorbidity was something that neurologists don't worry about. You know, it's got a nervous system, somebody else can worry about the rest of it. But lots of you have been to the 2 brilliant talks that Chris Bogren did on caudal cervical spondylomyelopathy and the excellent talk on pugs. And I just thought, well, and their thoracolumbar myelopathies, I thought both of those are patients or groups of patients that for me as an anaesthetist have got pretty significant comorbidities. You know, the pugs are also brachycephalic and, you know, they're at high risk of regurg, etc. The Dobermans have DCM, they've got von Willebrand's disease, bleeding tendencies, they're having long surgeries. So I thought a bit of a chat about perspective and comorbidity might not be a bad idea. Laurent, could I have the next slide, please?
Remember, she used to be bossy and she still is.
This used to be Laurent's life and it isn't anymore, but this is mine. Friday at 4 o'clock. I have an emergency that's tetraparetic. This is the duty neurologist. It sounds like it'll need its head and neck, its neck scanning, sorry, and maybe surgery. It's a neck, it needs something doing. Well, I'm a little bit more worried than that. Take a look at the slide. On the left, we've got, this is actually my dog, sighthound lurchery type thing. And on the right, we've got the archetypal French bulldog, one of the most popular breeds, unfortunately, in the UK, and one with a lot of neurological problems as well as significant comorbidity. So I just wanted to have a 5-minute chat about which of these do I worry about and why, and get you as neurologists to think outside the box a bit. Should I have the next slide, please, Laurent? So, bit of risk assessment here. I don't know much neurology, but a little bit has rubbed off. So if we look at our patient on the left, why is it presenting? It's likely, you know, this is a lurcher. It's likely an FCE or an acute non-compressive nucleus pulposus extrusion. I'm happy, it's not likely to be surgical. Nobody's going to be cutting at midnight. From a dog perspective, these are often, they're nice dogs, they're amenable, they're very rarely aggressive. They're also canine athletes. Their cardiovascular function is actually 4 times that of Mo Farah's if you do the maths on it. You've got to work really hard to cause them a cardiovascular problem. They've got huge airways, massive ET tube, and they've got a pretty low incidence of relevant comorbidities. They tend to be pretty healthy dogs. And they do tend to be hypertensive, and there's a thromboembolic risk. But for an MRI, am I really worried? Not really. This is a big dog as well. He's around about 30 kilos. A risk of hypothermia, pretty low. What am I going to do? Well, if it wasn't my own dog, this is a picture of my own dog, I'd be going home and letting an intern do it. This is not a high risk case to me. I've gone through the risk assessment, and with any luck, this will be a quick MRI, a diagnosis, and you know, non-surgical management. The guy on the right, this is our Friday bread and butter. French bulldog presents tetraparetic, going tetraplegic. Being told it's a C1, C5 neurolocalization. That's telling me, even though I don't know very much, that it's likely to be surgical. It's probably traveled to us about 2 hours because we're a referral center, and this may apply to lots of you as well. They're prone to hypothermia and they tend to get very stressed. A lot of the cases we see are aggressive as well or not very well mannered. So we now have a patient who is hypothermic, potentially dyspneic, aggressive, and can't walk. Great. In addition to that, most of these dogs suffer from brachycephalic obstructive airway syndrome. They are at risk of ocular ulceration, and a very large proportion of them regurgitate on a regular basis, which a lot of owners frankly think is normal. They have a high incidence of hiatal hernia and a high incidence of gut disease. All sounds brilliant before we start. In addition to this, this is likely surgical. So we've got surgical risk to consider. Depends on your surgeon, but some make them bleed more than others. We've also got a risk with neck surgery of venous air embolism because of the positioning. We have a risk of neurodeterioration. You know, no disrespect to any surgeon, but we're operating on a damaged area. It is quite possible, particularly with a high cervical disc, that we could finish up with a patient that is neurologically worse after surgery, and that could go as far as not being able to breathe. It's uncommon, but I've seen it many times. It does happen. In addition, these guys, they don't have the airway of the lurcher. We might get a 5mm, 5.5mm endotracheal tube into this. It's going to have a long MRI on surgery. It's going to be anaesthetized for hours. There is a significant risk of airway obstruction in recovery. There's a risk of regurgitation in recovery. I'm worried, prepared for a long night. The owners need to be aware that this is not entirely straightforward. So that's kind of what I'm talking about in terms of risk assessment. From a neurologist point of view, we've got 2 dogs with neck problems. From an anaesthetist point of view, we've got 2 very, very different candidates. Next slide, please, Laurent. So is something that, you know, many of you have to encounter, even if you don't particularly want to do anaesthesia, if you literally do just want to keep them still. But this is a review that was written by a couple of my colleagues at Davies, Fran Downing and Sarah Gibson, and it is really readable. It's free access, so you don't need to subscribe. It's an open access article. Gives you a really good overview of how to sensibly anaesthetize a brachycephalic. So the things to take into consideration, with the hope that whatever happens by the end of the anaesthesia, the dog is not in a worse situation than where we started. So that's my lecture on comorbidity.
Excellent. Well, as neurologists, what are some of the issues arising from our sick and emergency cases that you would like to bring some attention to?
Well, I guess I'm here because it's a neurology thing. So, Laurent, could I have the next slide, please? There are lots of things lots of presentations that I'm concerned about. You know, we're doing complex spinal surgery. We've got risks associated with that. We've got severe neuromuscular disease. We've got risks associated with that. But in terms of, I guess, the biggie is intracranial disease. Intracranial disease is something that we see manifestations of on a very regular basis. And from my point of view, any animal with intracranial disease could potentially be a problem. Next slide, please, Laurent. When I'm talking about intracranial disease, I guess we're really talking about space-occupying lesions, because from the point of view of what's going on inside your head, if you have a space-occupying lesion, by definition, you've got a change in the intracranial anatomy and potentially in a change in the intracranial physiology and a raised intracranial pressure. So if we think about it, the cranium's a pretty rigid vault. It's a box, you know, and it contains stuff. And that stuff is basically non-compliant brain tissue, blood in order to perfuse that brain, and CSF. So, you know, I don't know much about neuroanatomy, but I need to know that they all need to coexist in a given space. If one of those elements increases in volume, so for example, we have edema secondary to secondary to all sorts of things, but we have edema secondary to a mass, we have inflammatory brain disease where the brain tissue itself is impacted, we have a large space occupying lesion. All of those will potentially increase the volume inside that cranial vault. The volume can't really do much, so something has to give. Either we lose our CSF, gets pushed out, our intracranial perfusion decreases, or ultimately we can potentially get herniation of brain material. And if we look at the bottom right, it just shows you a relationship between intracranial pressure and intracranial volume, that you get a pretty linear relationship initially, and then you get a point at which everything basically decompensates. And and intracranial pressure rises very, very quickly. And that's something that everybody is worried about, both neurologists and anaesthetists, because we're aiming to help you get a diagnosis by anaesthetizing this patient. But if we do things wrong, the things that we do during anaesthesia can actually take a patient from just to the left of that inflection point to the right of it. And when that happens, if the brain herniates, kind of it's game over. So we really don't want to make ourselves desperately unpopular with a neurologist by doing that. So it's our attempt to try and use pharmacology and use management to manage intracranial physiology. Could I have the next slide, please? So this is a really big topic, but I just thought I'd cover it kind of briefly just to give you a bit of an overview of what's important. And it's not so much how you do it, we'll talk about that a little bit, but what you need to think about. There are three real drivers: cerebral perfusion pressure, which is essentially the driving pressure to deliver blood to the brain. And that really has to be prioritized in all neuro patients all the time. So whatever anybody else says about managing anything else, it is the perfusion pressure to the brain that has been most correlated with outcome, if you look at that. And that perfusion pressure is determined by what the blood pressure is, taking away the intracranial pressure. So clearly, the higher the intracranial pressure, the higher the perfusion pressure needs to be in order to maintain adequate perfusion, and hence the higher the mean arterial pressure needs to be. So we need to think about that. CMR is basically cerebral metabolic rate for oxygenation, which basically in any other terms means that the brain needs blood because the blood carries oxygen, because the brain uses a lot of oxygen. That's about as much as an anaesthetist that I need to know. But we need to deliver oxygen, and we need to deliver enough oxygen. And we need to deliver enough oxygen in enough blood, but not too much blood. If you think about what I said about the cranial vault, if you've got too much blood in there, it just increases the pressure. So we need to make sure there's enough blood going to the brain, but not so much blood that it just makes the intracranial pressure situation worse. So we're thinking about blood going to the brain, blood delivering oxygen to the brain. Next slide, please. So the brain needs oxygen, and it needs a substrate, which is glucose for aerobic metabolism, given by enough but not too much blood. So what can affect what is enough but not too much blood? Well, there's various things, and those can be mitigated and managed by anaesthesia. And it's important that all these auto-regulatory processes, we need to be aware of that. If we've had trauma, ischemia, a lot of it is lost, so everything becomes slightly pressure dependent. But I guess there's various fairly kind of basic but important take-home messages. A lack of oxygen causes blood vessels to vasodilate. So we've got an attempt to deliver blood, a hypoxic response. If your levels of oxygen are pretty much normal, then the blood vessels will behave fairly well. In terms of ventilation, if your patient has too much CO2 in their blood, so too much carbon dioxide, which is that carbon dioxide is retained because they're not breathing well, that carbon dioxide causes the blood vessels to dilate and delivers too much blood to the brain. So what we're trying to do with a lot of our management is actually to make sure that cerebral perfusion pressure and cerebral blood flow are adequate, but not excess. So that'd be a couple of kind of physiological take homes. As I said, we don't have that much time, but if we could go on to the next slide. So how does this play out in reality? What are we actually going to do with these patients? Well, as I said, we need to make sure that they're not hypoxic. So oxygen if needed, especially if they're a polytrauma patient. I'm not going to go into that in vast amounts of detail, but I would say no nasal prongs. You don't want them coughing, sneezing, or causing more problems. Manage hypoperfusion. This is really important. Laurent and I have lost count of the number of patients that we've seen that have had lots of drugs to try and reduce intracranial pressure, but at the same time, they have no blood pressure. So we need to make sure we manage that driving pressure to the brain, and that might require quite a lot of volume support. We need to make sure that they're ventilating properly. Now, if they've had head trauma, they might not be breathing very well. That's something we need to support ourselves. And we need to think about specific management of intracranial pressure. These are all things that are basically happening in a dynamic manner from the time that the patient presents to us. There's lots of other things that we think about, and at this point I'm going to give a plug to Laurent and Simon's book, the Neuroemergencies book, which has been out a few years now, but has got some really good stuff on how to manage these cases on initial presentation, because it's what you do in that small window of opportunity that makes a big difference. If we're now going to anaesthetize these patients, we need to make sure, as I've gone on about, that the tissue is getting enough oxygen, and that tissue is getting enough oxygen because it has enough blood being driven by an adequate pressure. And we need to give make sure the intracranial pressure is controlled. So all those things, you know, we've already said. The next question then is, how do we actually do this? Could I have the next slide, please, Laurent? So assuming we've had a pretty good go at stabilization, we've got an animal who's not hypoxic. Blue is a bad color. Try and make sure that they are adequately oxygenating, that they are ventilating reasonably, that they have an adequate mean arterial pressure, and that might require volume support. It might even require blood, depending on what's happened to the amount of hemoglobin they've got. It might require pressure support. It might require inotrope support. It really depends on how sick they are. But anaesthesia is not going to help any of these things other than controlling ventilation. So we need to ideally get as much stuff of that under control as possible. So every case is different, but there are a few basic tenets that are really important, and how to do the best job with these guys. To start with, any pre-anesthetic medication, ideally administered IV, be short-acting. We don't want this patient sedated for 6 hours. Laurent gets quite upset if you can't do a neuro assessment pretty quickly to make sure that things are going well. Don't upset your neurologist is a good take-home message as well. So IV, short-acting pre-meds. I would avoid acepromazine. It's a vasodilator. It acts for a very long time. Avoid high-dose alpha-2 agonists. Now, I'm not saying avoid alpha-2s. That's an entire other lecture in itself. And they are widely used in human neuroanesthesia, but at very, very small doses. And avoid morphine, because coughing and vomiting are a really bad thing. Pre-oxygenate by mask, ideally tight-fitting so that you can ventilate if necessary. Position them carefully. You want the head up about 30 degrees. That'll optimize your cerebral perfusion and minimize your intracranial pressure. But make sure that you are not forcing them into this position. You know, stressing a cat to get it in this position is somewhat suboptimal. Your induction of anesthesia should be really smooth and high quality. You want to give your drugs IV to effect. To be honest, whatever you're most familiar with is probably a good thing. We can debate ketamine in the questions if people want to talk about it, but high quality induction, rapid attainment of airway without coughing. You may want to use spray local or IV lidocaine. Both work pretty well. We've got various studies looking at those. Get your tube in and get control of your ventilation. So that could be using a ventilator, or it just could be using manual, a manual way of squeezing the bag, basically. We'd be looking, if you can, to maintain anesthesia with sevoflurane vaporized in oxygen and air, no nitrous. You could use propofol VRI. Avoid isoflurane, definitely avoid halothane if you can. I appreciate not everybody's in the same situation as me, but there are multiple reasons for that. But ultimately, either sevoflurane or propofol have better what are called demand delivery kinetics in the brain. So basically, they mean that they don't affect cerebral vascular tone as much, or cerebral oxygen demand delivery kinetics. We need to keep this patient anaesthetized, and we don't want to use loads of Sevo. A, it's expensive, which upsets my boss, and B, we want to keep the anesthesia nice and stable. So we give low dose opioids, but short acting stuff. So I'm thinking about maybe if you've got it, a little bit of fentanyl, you could consider butorphanol, even pethidine, but that has to go IM. Don't use anything like buprenorphine. Again, it's really long acting. It'll upset the wrong bad thing to do. Ventilate to normal capnia, not massively aggressive, but keep your CO2 within normal limits, ideally low end of normal. We can talk further if people want strategies to manage problems with intracranial pressure, but potentially the use of hypertonic saline solutions, potentially mannitol. We talked about position, we talked about fluids, and ventilation to normal capnia with ventilation strategies that don't use PEEP, they don't use positive end expiratory pressure, and they maintain a fairly low peak inspiratory pressure, which has less effect on venous return. And we need to monitor these patients. This is the bit that's really important. Anesthesia is not chemical restraint. It's perioperative medicine. That's what I'd like to elevate myself to, a perioperative medic. We need to monitor pulse oximetry, we need to monitor non-invasive blood pressure and end tidal CO2. I would consider those as pretty much bare minimum, because that gives us the data we need. Are we ventilating them effectively? Are we perfusing the tissue reasonably well? Are they maintaining their saturation? I'd also want ECG, temperature, inspired agents, invasive pressures, etc., but I realize people don't necessarily have those. And if we're talking about intracranial surgery, then you need to do a good job, because anesthesia really does affect outcome in these guys. So that's kind of a nutshell, and I've come in at about 25 minutes. So yeah, that's kind of intracranial anesthesia in a nutshell.
Well, thanks for that. Very, very concise. But I guess the question is, with all of what you've got going on there, is it all necessary if you just wanted to put patient into an MRI, if we weren't talking about surgery?
I mean, we all have to make compromises, but there are plenty of cases that I can remember, a couple that stand out, where we've anaesthetized them as if they didn't have something going on in their brain, and they subsequently were found out to have so, and their recoveries and their general progress after anesthesia was not very good. So I think, you know, you're managing an extremely vulnerable organ. You know, neurologists are quite worried about brains. So I think, you know, you're basically just working with the physiology in there. So it's just about taking due care and attention, basically, because if these go wrong, they can go catastrophically wrong. If your dog with a brain tumor herniates in MRI, well, it, you know, completely herniates. It's too late. You can't even think about options for the owner, because, you know, it's anesthetic mortality. So I would say do the best job you can. It's not always going to be perfect, but it does make a difference. Attention to detail really does.
All right. Well, what would be your take-home messages then, your summary of this for the non-anaesthetists that are listening?
I guess think about the whole patient, not just the neurological system. And that means think about the comorbidities that it's rocked up with and how we're going to manage those. You know, think about engaging with the owner with that, because, you know, the last thing we want is something like, you know, a French bulldog or maybe a pug to have an MRI to prove that it's got something that you're not going to be doing surgery on, and then to spend the next week regurgitating and the owner being extremely distressed. So, you know, just be aware of that. That we're talking about chip on shoulder anaesthetist, perioperative medicine, not chemical restraint. There is a very big difference. You know, just think about the physiology. You guys are really good at thinking about physiology and a logical approach. That's all anesthesia is, just a logical approach. It's just a different logical approach. And that, you know, good anesthesia contributes to positive outcomes. We know that on an anecdotal basis from our own cases, but we know that in a much bigger way from a lot of the human data that's coming out. So, you know, it's something that goes along with being a good clinician.
All right. So well, thank you very much for that. I realise that it's very difficult in 30 minutes to put everything together as a do's and don'ts, a summary of the anaesthetic pitfalls of the neurologic case. But I think you've done a fantastic job there in bringing out the most important points. I'm going to hand you back to Laurent, because no doubt we've got a few questions that people have sent in. So hand you back, and thanks again for what you've done so far.
Thank you, and feel free to put your question in the comment box. So we've got to put the first question. Do you use, let me put it there, do you use mannitol or hypertonic saline in the context of raised intracranial pressure? For example, you got a dog with brain tumor or an MRI look like he's herniating. Which one do you use? And why?
That's a question subject to a very recent review. There is not particularly really strong evidence to support one over the other. Generally, there is evidence from humans in various different things, like in subarachnoid hemorrhage, in traumatic brain injury. There is evidence of hypertonic saline being beneficial. The other issue is that we call hypertonic saline. That could be anything from 3% sodium chloride to 23% sodium chloride. So we need to think about what we're actually talking about. We actually do use both, and because I wouldn't use hypertonic saline in a patient that already is either volume overloaded or has a really high sodium, which are kind of things that we do get presented with as well. So mannitol is potentially slightly safer in those cases, whereas there is evidence that hypertonic saline is better if the patient's at risk of acute kidney injury. So I would say both. But that said, the big recent human review suggests that, you know, if you haven't got one, then use the other. But neither in the human literature are they both impact intracranial pressure and impact the amount of edema that's there, but neither of them have a massive effect on outcome. So I think it's really important that the thing that's been shown to have the biggest effect on outcome is maintaining cerebral perfusion pressure. So don't obsess about that, particularly in the traumatic brain injury cases where you really need to think about global hyperperfusion as being a problem. Does that make sense?
Very good. Next one, do you use steroid IV in the case of head trauma if all the other treatment modality have been
we don't. You guys probably know more of the more recent literature than me, but essentially you don't want to create a situation of an increase in glucose metabolism and potentially lactate, which will damage the cells itself. No, it's not something that we would do.
It's putting oil on the fire. Would be the
yeah,
best
I mean, absolutely. It's not, it's not indicated. And you know, we struggle enough with hyperglycemia in some of these patients anyway without putting steroids in there as well.
Do you use local anesthesia, lidocaine, for hemilaminectomy?
We don't tend to, but we do use it. Use it quite a bit, and I've done quite a few of these cases with Laurent with dorsal laminectomies at the LS, where you're digging around at the nerve roots, where we've applied local directly, and that's been effective. But it needs to be done in a kind of in consideration, because one of my neurosurgeons will not allow us to do it because they're too worried about the effect of the local afterwards, even though lidocaine is pretty short acting. So certainly where we've used it around nerve roots, I think Laurent would agree that it's been effective in those cases where we're doing that kind of stuff. There is better evidence, actually. There's a paper published from Dick White's from a few years ago for epidural morphine being applied directly, and it has a much longer duration of action. I would, however, we have no data on AN cervical stuff, so we're talking about TL stuff here. I'd be relatively concerned about cranial spread if you're going to think about doing anything in the cervical area.
Your favorite drug? What is your opinion of using small dose of ketamine in patients with seizure? It's not really the topic, but it'll be interesting to hear your view. I know.
I mean, I certainly wouldn't use it. We tend to discuss these cases and we'd use it as a third or fourth line drug. I wouldn't be using it as a first line drug. That said, we use loads of ketamine, and we use it in every single hemilaminectomy and almost dorsal laminectomies and ventral slots and anything else I can give it to. And the basis on that is that it is a proven preventive analgesic, and there's data just come out of the US showing that chronic pain is present in dogs in a proportion of dogs that have undergone a hemilaminectomy. And I was just interested to note that they weren't using ketamine. So whether it makes any difference or not, we don't know. But certainly, I think Laurent is a big fan of ketamine in terms of reducing the amount of opioid we use, the amount of things like constipation, regurgitation. So I, in terms of ketamine in seizures, not a big fan. In terms of ketamine in neurosurgery, a very big fan.
I love ketamine for surgery, definitely. We see if there's any other question posted. I've got two questions. The first one is, I got a friend. He's getting a bit old. He's been trying to be a neurologist for the last 23 years. He's getting a bit slow.
Here we go.
And, he has tendency when we do webinar to blank a bit.
It's not fair to pick on Jack if he's not here.
Yeah.
I have to like, prod him when we do talk like that. If there's anything I could give him to try to improve his
I can think of a few things, but they might not be suitable for public broadcast. But yeah, there's a few cerebral vasodilators out there that might be worthwhile.
I think he's tried a few vasodilators, but not. Okay. The other question is, which of the two was the worst nightmare to work with?
What, you or Jack?
Between me and Simon.
He's not here at the moment, but yeah.
Between me and Simon, which one was the worst? And do you have any case in mind?
I do remember one just after I started at the trust, having come from Edinburgh, that was bleeding, shall we say, inverted commas, a lot. And I said, Laurent, are you okay if I transfuse this? I'm a bit worried about it. And you said, pardon the language, my dear, you do all that you like, just keep it alive for me. And I thought that's the beginnings of a healthy relationship.
That's on the very, the way I tend to communicate. There is no more question. Louise, thank you so much. It's lovely to see you again. I hope we're not going to wait another 18 years to have you back. But as always, thank you. And as I say, Louise is a very safe pair of hands. If you're a surgeon, at least you can focus on your surgery without worrying about anything else, without a doubt. Simon, I'll let you give the last word. I think it's only fair after the nice point I make about distributor. And,
no, I couldn't possibly be so childish, but I do want to thank Louise for coming on. Excellent synopsis there. Next time we probably have you on to discuss transfusion medicine, as that one case that you remember, Louise, was actually one of like 85% of Laurent's hemilaminectomies. So
I had a ventral slot with him bleed to a flat art line.
Yeah.
Went home 2 days later.
Yeah. All right. Well, thank you very much. Really appreciate it. It's good to see you again. Thanks.
And thank you very much for the invitation. And I hope everybody learned something of use from that.
Thanks very much, guys. So next week we'll take a break. There will be no Facebook Live, but then we'll move on in 2 weeks' time. We will start our monthly journal club. And after that, we'll have a neuroimaging Facebook Live. That will be early July. So thanks a lot, everyone. And hope you have a lovely evening. Have a good day. Bye-bye.
Thanks. Bye-bye.
Thanks, everyone.